Good afternoon, esteemed Organizing Committee of the International Conference on Radiation Medicine 2022 and other collaborators, delegates from India and abroad, my dear colleagues and friends. This side Misbah Hamid Baba, a PhD scholar from the Department of Physics, GLA University, Mathura, India, as well as a research officer from the Department of Radiological Physics and Bioengineering, Sher-e Kashmir Institute of Medical Sciences, Srinagar, Jammu and Kashmir, India, would like to thank ICRM 2022 Organizing Committee to give me an opportunity to present my piece of research. The topic for today's presentation is skin sparing in intensity modulated radiation therapy of head and neck cancers. This is the abstract that has been selected for today's presentation. Background and purpose. Radiation therapy of head and neck cancers involve high doses to the target structures, which are superficial to the skin surfaces. This leads to a break in the radiation therapy, which overall affects the local control and the cure rates. As a result, the skin toxicities involved are higher and sometimes worsens to such an extent that radiotherapy needs to be interrupted unplanned. Therefore, in this study, we have tried to drop down the skin dose by contouring the skin as an organ at risk and evaluate the dose volume histograms to skin without compromising on the planning target volume dose coverage. Materials and methods. 73 cases of nasopharyngeal carcinoma patients receiving adjuvant radiotherapy of 70 gray were selected for this study. CT simulation of all the patients was done using wide bore CTs from Siemens known as somatome sensation with contrast dye, and a slice thickness of 3 mm was selected. The CT datasets in DICOM RT format were transferred to the Eclipse treatment planning system version 13.6 via ARIA network, in which Soma Vision workstation was used to delineate the target and organs at risk. Normally, skin is not contoured as an organ at risk for head and neck cancers. But for these 73 patients, 3 mm skin inside the body was contoured as an organ at risk. Study patients were divided in 3 groups, with group 1 that received 70 gray by simple IMRT in 2 phases and was named as IMRT phase 1 and phase 2. Group 2 also received 70 gray by a technique known as skin spared IMRT in 2 phases, and this was named as IMRT phase 1 and phase 2. And group 3 skin spared simultaneously instantaneous boost IMRT named as SABR IMRT. All the plans were planned using Eclipse treatment planning system. Volume doses were calculated using anisotropic analytical algorithm with a calculation grid size of 0.25 cm, and fluence was optimized using dose volume optimizer version 13.6.26 of Eclipse treatment planning system. The plans were compared by the dose volume histograms and dose statistics to the PTV volumes as well as to the organs at risk. The organ at risk was skin in this research. For PTV, D mean, D max, D minimum were compared. For organs at risk, D mean was used for comparison. The skin doses to various volumes, from volume of skin to receive 5 gray to volume of skin receiving 70 gray, were evaluated and compared. In this abstract, only volume to receive 20 gray is reported. The analysis was done using data editor of IBM SPSS version 26 from Chicago, USA. One-way ANOVA analysis was used to assess the differences in the skin doses between the 3 techniques. The comparative datasets were evaluated on 5% level of significance, that is, p-value less than 0.05% was considered statistically significant. This is a representative case showing that how IMRT plans were planned using Eclipse treatment planning system. Results. When the skin was considered as an organ at risk, the skin volume to receive 20 gray was reduced by 22% by skin spared IMRT phase 1 and phase 2, and by 7% using the technique of skin sparing SABR IMRT. There was a significant effect on the dose reduction to the volume receiving 20 gray at the p-value less than 0.05% level for 3 conditions: F 2 and 216 equal to 2431 with a p-value less than 0.05. The mean and the standard deviation of the three techniques were as follows. For simple IMRT phase 1 and phase 2, a mean dose of 65 gray was observed with a standard deviation of 0.7 gray. For skin sparing SIB IMRT, a mean dose of 60 gray was observed with a standard deviation of 1.09 gray, and for skin spared IMRT phase 1 and phase 2, mean dose of 53 gray and a standard deviation of 1.2 gray was observed. These are the descriptives, that is mean and the standard deviation, found by one-way ANOVA. This is the significant level found on the intercomparison of the three techniques. The difference was quite significant. These are the one-way ANOVA results. This is a graph showing skin to receive 20 gray volume by three techniques, showing a decreasing trend from simple IMRT phase 1 and phase 2 plan to skin spared SIB IMRT and to skin spared IMRT planned in phase 1 and phase 2. This is the same box plot showing the same trend with the median values and the second quartile and fourth quartile values for the three techniques. This is a representative case showing volume of skin to receive 20 gray by two techniques, that is simple IMRT phase 1 and phase 2 and skin spared IMRT phase 1 and phase 2. This is the same representative case showing a dose difference of the volume of the 20% of the volume to receive 20 gray by two techniques, that is skin spared SIB IMRT and skin spared IMRT in phase 1 and phase 2. Conclusions. Skin sparing IMRT for head and neck cancers can be useful to bring down the skin doses as well as the related toxicities. We recommend that skin should be contoured as an organ at risk for head and neck irradiations in order to have a better disease control with lesser toxicities and less unplanned treatment interruptions. Of course, limitations are there. And there is a future scope also. In this study, the limitation of this study was that we have only compared the TPS calculated doses for skin sparing by three techniques. In future, TPS calculated skin dose can be measured in vivo to find the difference in the calculated and mean doses. Yes, I would like to acknowledge ICRM 2022, King Faisal Specialist Hospital and Research Center organizing and academic committee as well as collaborators for abstract and oral presentation selection. I would like to thank Head of the Department of Physics, GLA University. I would also like to express my thanks to my PhD guide, Dr. Binoy Kumar Singh. At last but not least, I would like to thank all my patients and the staff of my department. Thank you all for a patient listening. Any questions?
Hello everyone, this is Rima Ahmadi, a medical physicist working in King Saud University Hospital, Oncology Center. I will talk to you today about VMAT planning for craniospinal irradiation cases using two different optimization algorithms. This work is done by me and Dr. Abdulaziz Al-Hazmi, Chief Medical Physicist at King Saud University Medical City Oncology Center. The motivation of this work is to evaluate the dosimetric characteristic and the treatment delivery parameter of two pediatric craniospinal irradiation VMAT plans generated by commercial optimization algorithm. To achieve this goal, we used Eclipse and Monaco TBS to produce VMAT-based plan to be delivered by Elekta Infinity Linac. Both plans have identical prescribed dose of 23.4 gray prescribed dose, considering the hospital guidelines for dose constraints of organ at risk. The Linac parameter of both plans set up were fixed to be four full arcs and 2 ISO center, while the optimization objectives were adjusted to for each TBS. Both plans beam setup are identical in beam energy and in arcs direction, and also beam angle, collimator angle, and also in beam isocenter. We have 2 isocenter. Every isocenter contains 2 arcs with different collimator angle of 45 angle and 0. We choose 45 because provide us of larger field that can cover up to 48.5 centimeter long target, while we set the collimator angle of 0 for the second arc could make the plan less susceptible to localization error of the beam isocenter. The 4 arcs were optimized at the same time. In the left we have Monaco optimization, and in the right we have Eclipse optimization. In Monaco optimization, we use for the BTV target penalty, target AOD, and max dose cost function. Target AOD helps to maintain the dose uniformity within the target. For organ at risk, we use max dose and parallel cost function to meet the dose constraints for these critical organs. To maintain the dose within the target, we usually use or create a structure called ring around the BTV. This what we did in Eclipse, but for Monaco we have a cost function that works as a ring around the BTV, which is the quadratic overdose. The sagittal dose distribution shows BTV covered by 95% of the prescribed dose. Here in the left we have Eclipse, and in the right we have Monaco. Both plans shows a decent coverage of the BTV. In terms of BTV coverage, the Eclipse-based plan exhibits slightly better coverage than Monaco-based plan. We see here in the left Eclipse, the debate for the BTV, that 95% of the volume 95% of the volume of the BTV covered by 98% of the dose in Eclipse plan. While in Monaco, we see here that the 95% of the volume is covered by 96% of the prescribed dose. As shown in the table, there is no significant difference in BTV doses between Monaco plan and Eclipse plan, but in terms of conformity index, Eclipse more conformal than Monaco plan. Monaco plan mean doses were higher than Eclipse for the larynx by 54%, oral cavity by 52%, and for both lungs about 20%, and both kidneys about 20% higher than Eclipse plan. In the end, both of the TBS are capable of producing VMAT-based plan for CSI cases that meet the clinical criteria. Yet Eclipse showed superiority over Monaco for organ at-risk sparing. Thank you so much for listening.
Hello, everyone, and thanks for the opportunity to present here today. My name is Usam Ghandoura, and my background is in radiation therapy. I did my master's and training in Sydney, Australia, and I recently finished my PhD at the University of New South Wales, also in Sydney. And today I'll present some of the work I did for my PhD, looking into estimating the optimal and actual utilization rates of lung SABR within the Australian population. So lung cancer, as you know, is a major cause of death. It is the fourth most common cancer diagnosis in Australia and responsible for almost a fifth of all cancer deaths. Survival rate after 5 years is only about 17%, which is pretty bad compared to other cancers, as you can see here. So stereotactic ablative body radiotherapy, or SABR, is currently the standard of care for inoperable early stage non-small lung cancer. For operable patients, surgery is still the gold standard, although there is still a big debate about which is better for these patients. And it's very hard to conduct randomized controlled trials in this setting. So many trials have already failed to recruit enough patients, and others are still trying, but the debate is still ongoing. However, the advantage of SABR over surgery, of course, is that it's very non-invasive and convenient for the patient. It offers excellent control rates with only a few outpatient visits, and it's also a lot more tolerable compared to conventional radiotherapy, which allows many more elderly patients and those with comorbidities or poor performance status to have this curative treatment instead of being referred to palliative or sometimes left untreated. We know from population studies also that since the introduction of SABR, the number of lung cancer patients undergoing curative treatment has significantly increased, while the number of patients left untreated has decreased, which ultimately led to improving the overall population survival. And so the reason why we want to estimate the optimal utilization rate is that it represents the total demand for the treatment that we have within the population. More specifically, it's the proportion of patients who are going to need this treatment at least once during the course of their illness. And so once we know this demand, we can use it as a benchmark to evaluate the actual utilization rate within our clinical practice. And this will hopefully help identify any potential gaps in service delivery and also help us make more informed decisions about the process of resource allocation and planning for more efficient delivery of radiotherapy treatment. Unfortunately, from the literature, we already know that radiotherapy in general is quite underutilized, and this is pretty much in every country, not just in Australia. And we also know that this underutilization has a negative impact on patient survival, leading to losses in years of potential life. And so there's more than one way to calculate the demand for any treatment. We use the evidence-based approach, which basically has two main steps. In the first one, we identify all the indications or the clinical scenarios for which SABR would be recommended. And this would be based on the best available evidence and guidelines that we have available. And then the next step is to look at the epidemiological data for our population and find the estimates or the incidence rates of these indications. And then we can combine all these ratios to find out the total demand for the treatment. And so this is just a list of all the guidelines that we reviewed. 15 of them from different countries and working groups like ISRO, ASCO, and NCCN and others. This table shows all the indications for lung SABR, and then all the guidelines that recommend SABR for these indications. And of course, the guidelines didn't always agree with each other. So we ranked the level of agreement between them from strong to weak. And we also ranked the quality of evidence used to justify using SABR for these indications. So this is our model or decision tree that we built up from reviewing all these guidelines. So we have all the different indications. And then at the end, we see whether or not SABR will be recommended. And then the next step, is that we looked at the population-based data from cancer registries or epidemiological studies, and we focused more on Australian data because we wanted the model to apply to the Australian population. But the really nice thing about this model is that if we wanted to apply it to a different population, say here in Saudi, for example, then all we have to do is replace these numbers with Saudi population data, and we should be able to do the same thing for here in Saudi. Unfortunately, what we were missing from the model was the proportion of peripheral, central, and ultracentral tumors. And as far as we know, this data hasn't been published. And so another part of my PhD was that we developed and validated an automatic segmentation tool that would be able to automatically contour the bronchus and then the distance to the tumor, which is how they commonly define tumor centrality. And this tool is fully automatic, which means that we can apply it on as many data sets as we want, sort of like in data mining. And we'll be able to do them very quickly without having to worry about the uncertainties of manual contouring and things like that. I wish I had more time to talk about this, but for now, I'll just refer you to this paper that we published a couple of years ago. And so this is the data set that we used. We had a total of 430 patients. Unfortunately, about 196 of them were missing the DICOM images, which we needed to run our algorithm. And so we ended up with only 234 patients. This is the distribution of the distances between the tumor and the bronchus for all these patients. And so this is the data that we needed, and we were finally able to complete our model with all the data. And now all we had to do was crunch all these numbers using some special software, and that would give us the optimal utilization rate for all these indications. So for example, for all lung cancer, 6% should be receiving SABR. For stage 1 and stage 2, 24% should be receiving SABR. And then if we look at all the way at the end here, 82% of inoperable stage 1 should be receiving SABR at least once during the course of their illness. We did some sensitivity analysis just to investigate the impact of variations within the data that we use in the model. And we found that the biggest variation was caused by different estimates of the number of patients who were considered operable. But overall, in the Monte Carlo simulations, all these uncertainties led to a variation between 4 to 6% in the total demand. We also looked at the actual utilization rates within our local center, Liverpool Hospital, and we found that out of 430 patients, about 15% received SABR, 58% received radical, and about 27% received palliative radiotherapy. This is just the same data broken down by stage. We also did some time trend analysis, and you can see the general trend is increased utilization of radiotherapy, especially for radical. And in here, you see we reviewed the practice pattern studies from different countries to find different estimates of actual utilization rates in different countries, including Australia. And you can see there's quite a bit of variation from 6 to 20%, for example, for stage 1. And then for inoperable stage 1, about from 14 to 55%. But as you can see, nobody is meeting the optimal utilization rates that we calculated. And so just to summarize, we used an evidence-based approach to calculate the optimal utilization rate or the demand for lung SABR in Australia. We looked at the actual utilization rate in our local center and in different countries, and we found that there was still quite a big gap between the optimal and utilization rate. And so we have this great treatment, this great curative treatment, and unfortunately, it's very underutilized. So in terms of future directions, I would love to be able to do this same investigation in the Saudi population. And like I said, it wouldn't be very hard to do as long as we have the data that we needed. Other things we could do is that we can build up on the model to help us calculate the survival benefits if we were to operate at an optimal level, or in other words, the impact of underutilizing lung SABR treatments in terms of patients' outcome. So that's it for me. I'd like to thank all my collaborators and thank you for listening. And also I'd like to thank Monaco University for sponsoring me during my study. Thank you.